Welcome to this e-course focused on HIV and aging. This module contains audio. Please adjust your speaker settings as necessary. You may activate the audio presentation of each slide by clicking on the audio icon, located in the bottom left or bottom right corner on each slide. To advance from one slide to the next, click the right arrow, if in slide show mode. Alternatively, you may be able to use the page down function, or simply click Open the desired slide. Click on the right arrow for a description of the e-course and to begin the module. This module is intended for providers of HIV prevention and care services for men and women living with HIV who are more than 50 years of age in resource-limited settings. It aims to enhance the competence and confidence of providers of HIV care to an increasingly aging population of people living with HIV and to raise awareness of HIV prevention in older adults. The module summarizes key issues related to HIV and aging. After completing this module, you will be able to 1. Understand the global and regional epidemiology of HIV and aging. 2. Describe challenges of HIV detection and screening for HIV in older adults. 3. Understand the concepts of chronic inflammation, premature aging, frailty, and HIV. 4. Describe the HIV prevention and care continuum challenges for older individuals. 5. Understand key issues related to antiretroviral therapy in the elderly. 6. Understand comorbidities in HIV and aging. In this module, we will cover the following topics: the epidemiology of HIV and aging, detection and screening for HIV in older adults, HIV prevention in older adults, chronic inflammation, premature aging, and frailty. Key considerations when caring for older people with HIV. Let's begin by summarizing the epidemiology of HIV and aging from a global perspective and from regional perspectives in Africa, Asia-Pacific, and North America. These are global data from the special supplement on HIV and aging produced by UNAIDS in 2013. You can clearly see the rising trend in the numbers of older patients in Western and Central Europe, North America, Eastern Europe and Central Asia, Latin America and the Caribbean, Sub-Saharan Africa, Asia and the Pacific, and the Middle East and North Africa. This is a global phenomenon, as the main driver is that more people with HIV are living longer and healthier lives as a result of more widespread access to life-saving HIV care and treatment. In Sub-Saharan Africa, HIV prevalence surveys generally include few or no older adults, so data are limited. But here are some examples of data that we do know of from surveys that included older adults, as reported by UNAIDS. In 2013, 5% of people living with HIV in Kenya were over 50 years of age. And in Eswatini, 13% of men and 7% of women living with HIV were between 60 and 64 years of age. UNAIDS reported in 2013 that 15% of all new infections in Sub-Saharan Africa were in people of at least 50 years of age. And modeling predicts that by the year 2040, 27% of HIV infections in Africa, equivalent to a total of 9.1 million prevalent infections, will be among older individuals. These data come from the Asia-Pacific region and show in the orange and red bars increasing numbers of people living with HIV over the age of 45, 50, 55, and 60, from now until 2025. These are 2016 data from the U.S. Center for Disease Control. Of the estimated 1.25 million people living with HIV in the USA, 37% were aged 50 years or older in 2011. That proportion had increased to 50% in 2015, and by 2020 it is predicted to reach 70%. We will now turn to the screening and prevention of HIV in older adults and how these are different from their younger counterparts. Older people are less likely to be offered HIV testing or to seek out HIV testing. Because they are also more likely to live alone, be single, lack a partner, and have fewer friends, they also lack the social support networks that younger people living with HIV may have. Further, older people living with HIV may face dual stigma from HIV and from aging, resulting in increased isolation and further diminished social support. Globally, Almost every HIV testing campaign features young people as the face of HIV risk. Our messaging around HIV prevention and testing therefore does not reach out to older people. There are also challenges with HIV prevention among older people, who, despite being sexually active, may have less HIV knowledge and awareness and perceive themselves as not at risk, even though they are just as likely to engage in sexual risk-taking behavior as younger people. Factors that may contribute to an increased risk of HIV acquisition in older adults include reduced mucosal and immunologic defenses, such as postmenopausal atrophic vaginitis, decreased condom use due to being less concerned about pregnancy, concerns about condom-associated erection dysfunction, and the increasing use of erectile dysfunction drugs. In addition, older adults are generally perceived as being at low risk for HIV, and screening for HIV in this population remains low. The key is to raise awareness on HIV and aging among both providers and patients. Older people need to be informed about the importance of understanding and preventing risky behaviors, using age-sensitive information and education. Finally, it is critical to encourage care providers to screen people of all ages for HIV infection. The next few slides will deal with the important concept of chronic inflammation as it relates to HIV and its implications on premature aging. We will also introduce the concept of frailty and HIV. This conceptual model of aging with HIV infection depicts how the combination of structural, behavioral, and direct HIV-related effects contribute to reduced quality of life and healthy lifespan. According to this model, structural inequities such as gender, race, education, and employment, plus biobehavioral factors such as alcohol and substance abuse, smoking, and low self-efficacy, combine with a chronic inflammatory state caused by HIV to drive ongoing immune activation, low resilience, and physical and neurocognitive impairment. Even with effective treatment and viral load suppression, inflammation continues to drive an increased risk of comorbidities as people with HIV live longer. In people living with HIV, inflammation contributes to earlier onset and increased frequency of cardiovascular disease, cancer, venous thromboembolism, type 2 diabetes, chronic obstructive airways disease, renal disease, bacterial pneumonia, cognitive dysfunction, depression, and frailty. In this study, investigators looked at 4 events: myocardial infarctions, end-stage renal disease, non-AIDS and AIDS-related cancers, and compared the frequency of events by age between those with and without HIV. As you can see in the graphs, the onset of these events is earlier and they are more frequent in people with HIV. What can be done to reduce inflammation during suppressive antiretroviral therapy? In addition to HIV as a driver of inflammation, lifestyle factors that also contribute to state of chronic inflammation include smoking, hazardous alcohol consumption, and obesity, while moderate exercise reduces inflammation. All people living with HIV should be advised to quit smoking, consume alcohol responsibly, lose weight if they are overweight, and exercise regularly. Let's summarize this section of the module. Despite optimal antiretroviral therapy and viral load suppression, HIV still shortens life expectancy and increases the prevalence of age-associated morbidities. Inflammation persists despite effective antiretroviral therapy. Interventions aimed at modifying lifestyle factors are important in the management of the older people with HIV. Let's examine now the concept of frailty and HIV. Frailty has been defined as a clinical syndrome in which 3 or more of the following criteria are present: unintentional weight loss, 4.5 kilograms in the past year, self-reported exhaustion, weakness as measured by grip strength, slow walking speed, and low physical activity. Greater than or equal to 3 criteria is defined as frail, 1 to 2 criteria as pre-frail, and 0 criteria as robust. These data are from the AGE4 cohort study in the Netherlands. As you can see from the figure in red and blue, frailty and pre-frailty occurred at an earlier age and were more common in people with HIV compared to people with no HIV. Overall prevalence of frailty was 10% among people with HIV, compared to 3% among people with no HIV. The remainder of this talk is focused on the clinical care of aging people with HIV. This table summarizes the continuum of care challenges in older people. There are 3 high-level challenges. 1. Social and behavioral. 2. Structural. And 3. Biological and physiological. Social and behavioral challenges include low rates of testing, low perception of risk and condom use, risky behavior, and isolation. Structural challenges include lack of awareness and services not tailored to the elderly, lack of access to service for non-HIV conditions, limited mobility, and poverty. Biologic and physiological challenges include suboptimal immunological response to ART, the impact of HIV and antiretroviral drugs on increasing rates of non-communicable diseases, and the risks associated with polypharmacy and drug interactions. Here's a high-level view of the key components of clinical care of the elderly with HIV. Starting at the top and going clockwise, we mentioned earlier the importance of the detection and screening for HIV in older adults and remembering that people can be at risk of HIV irrespective of age. Next, when and what to start. Emphasizing that ART should be started immediately in everyone including the elderly, followed by screening for comorbidities and risk factors and how these comorbidities might affect the choice of ART. Next, promoting lifestyle changes, including healthy diet, smoking cessation, increased physical activity, and sexual health counseling. Next, the importance of polypharmacy and potential drug interactions in elderly people with HIV, who may take many other medications in addition to their antiretroviral therapy. Next, the importance of not only screening for comorbidities, but managing them in the context of somebody who also has HIV. As we reviewed earlier, comorbidities occur earlier and more frequently in people with HIV infection. And finally, the importance of offering opt-out HIV screening for all adults regardless of age or individual risk factors. Now let us briefly look at initiation and monitoring antiretroviral therapy in older people. There are no data to support a preference for any of the initial regimens based on age, but the choice should be based on the presence or not of specific clinical conditions, such as renal disease, elevated risk for cardiovascular disease, or osteoporosis. There is no evidence that the virological response to ART is different in older patients than in younger patients. However, CD4 T-cell recovery after starting ART generally is less robust in older patients than in younger patients. People living with HIV over the age of 50 should be monitored for efficacy and safety the same as other populations. However, special attention should be paid to the potential for adverse effects of ART on renal, liver, cardiovascular, metabolic, and bone health. The last major heading of the module is comorbidities. The next 2 slides provide a high-level view. For more information on HIV and non-communicable diseases, please refer to the training module on the integrated management of HIV and non-communicable diseases. As people with HIV are living longer, they are facing different health challenges, and cardiovascular disease is now one of the leading causes of death. There is also an increased incidence of non-AIDS-related cancers in older people with HIV, and older people with HIV have significantly increased bone density loss compared to age-matched controls. Many other age-associated comorbidities occur more frequently in people living with HIV compared to those who do not have HIV infection. These comorbidities include chronic obstructive pulmonary disease, liver and kidney disease, cognitive decline, non-AIDS infections such as bacterial pneumonia and frailty. Let's conclude by reviewing the core principles of good geriatric care in people with or without HIV. These are patient-centered care supported by social networks, patient involvement in care decisions, managing polypharmacy, and the need for integrated care across the many conditions that the elderly may have. Let's reflect upon the content of this module. Can you answer these questions? Why are the numbers of older people living with HIV increasing? Why are older people less likely to be offered HIV testing? How is chronic inflammation related to HIV premature aging? What is frailty? What are 3 types of continuum of care challenges in older people? Is initiation and monitoring of ART any different in older people with HIV? Which age-associated comorbidities occur more frequently in people living with HIV? This concludes the training module on HIV and aging. Thank you for your participation. You may now exit the presentation.